In this session, we have 4 talks on the nightmares of every endoscopist, ERCP-related complications.
As already said, we point out the risk factors for adverse events. There are some definite risk factors and more likely risk factors. They can be patient-related or procedure-related. As definite patient-related risk factors in the guidelines, they state that the suspected sphincter of Oddi dysfunction is a risk factor. You can also always see the odds ratio for the risk factors. Patients with female patients with previous pancreatitis or previous post-ERCP pancreatitis. More likely risk factors are a younger age, non-dilated extrahepatic bile ducts, no chronic pancreatitis, and a normal serum bilirubin level. Patients with end-stage renal disease are also having a higher risk of post-ERCP pancreatitis. Related to the procedure, from the previous session, we know that the difficult cannulation is a risk factor for post-ERCP pancreatitis. If you have more than one time a guide wire in the pancreatic duct, or if you inject contrast in the pancreatic duct. And likely risk factors are controversial, a precut sphincterotomy, pancreatic sphincterotomy, when you dilate, when you perform a large balloon dilation of an intact sphincter, when you cannot clear the bile duct from stones, or when you do an intraductal ultrasound. Also, an issue that is not in the guidelines but is often discussed is whether endoscopists with a high volume or a low volume have more risk for post-ERCP pancreatitis. The first study is in a meta-analysis, and they saw that there was no risk, that there was no association with post-ERCP pancreatitis regarding the volume of the endoscopist. Another thing are the trainees, so less experienced operators who have less than 200 procedure. Then there was an observational study that showed a higher rate of post-ERCP pancreatitis because of the higher rate of difficulties with cannulation. But having a trainee involved in other studies has not demonstrated to increase the risk of post-ERCP pancreatitis. And some studies try to address this, how to train people in ERCP and how to make sure that you have no more complications. For example, in this study, they made a protocol which is actually based on common sense. I think we all do it kind of this way, but of course for a study you need a protocol. And they state that hands-on training was excluded if patients were very sick, and that trainees could had to stop with the procedure when they failed 5 times for their cannulation, or when it was unsuccessful for more than 10 minutes, when the papille got swollen, or when they had more than 2 times a cannulation of the pancreatic duct. And when they introduced this protocol, they found no more adverse events when ERCPs were performed by trainees. The ESKA guidelines has some recommendation how to prevent post-ERCP pancreatitis. I think they're well known. They state that every patient without contraindications should get 100 milligram of diclofenac or indomethacin rectally immediately before the procedure. And that prophylactic stenting should be performed in selected patients at high risk, but we will come back to that later. And they actually recommend against placing a pancreatic stent in patients who have a post-ERCP pancreatitis, which is logical. So this algorithm, I think a lot of people have already seen before, but I will take you through it step by step to make it a bit more clear. So of course, the base of the recommendation is to give everybody NSAIDs unless they have contraindications. And in the ESKA guidelines, they state that pregnancy more than 30 weeks and having a severe allergic reaction is a contraindication. We discussed this already a lot of times with our nephrologist, and they say that kidney function cannot be a contraindication for one-time administration of NSAIDs prior to the procedure. And then it depends a bit on how the procedure evolves. If you have a standard cannulation, or a difficult cannulation, it depends on whether you have an easy pancreatic stenting possibility or not. So they define a difficult cannulation as having more than 5 contacts with the papilla, or having more than 5 minutes cannulation attempts, or having more than one unintended cannulation of the main pancreatic duct. So that's the definition of a difficult cannulation in the guidelines. They state that when you do not have a wire in the pancreatic duct, then no further intervention should be done. But if you're in the situation where you had repeated main pancreatic duct cannulation, or you used the double guide wire cannulation technique, or you performed a transpancreatic sphincterotomy and you still have your wire in the pancreatic duct and it's easy to place a stent, then a stent should be placed. And for this, a short 5 French pancreatic stent, a plastic stent, is recommended without an internal flange because it's supposed to migrate spontaneously, but with a flange or pigtail on the duodenal side.
So there are also some technique-related risk factors like the pre-cut needle sphincterotomy and also the use of a pure cut current, which can cause a zipper cut, so a very fast cut that's much longer and faster than you expected. And the papillectomy or the ampulectomy is also a risk factor for bleeding. Then the operated-related risk factor is all related with experience. So the less experienced endoscopist see more bleeding, and also the persons of the operators who perform less than 50 procedures a year have a higher rate of bleeding. So there are some misunderstandings also. For example, the use of aspirin or NSAIDs is not a risk factor for bleeding. Also, the length of the sphincterotomy is not a risk factor of bleeding. Some people are afraid to cut a little bit further, but if you cut in the right direction, there's no higher incidence of bleeding. It's even good to make a large sphincterotomy, especially when you have to deal with big stones. It can facilitate the rest of your procedure. So we're lucky that if we don't succeed and stop our bleeding, we have now our radiologist. And if you have an experienced radiologist, they have a very high success ratio between 80 and 100% of stopping your bleeding with angiography and embolization. Surgery, I think the need for surgery is luckily dramatically dropped. But because the older data of surgery were together with very high mortality of even 50%. It was a very difficult surgery in a bad patient. They had to do a sphincteroplasty and oversewing the bleeding. So we're happy that we now have good radiologists which can help us in severe bleeding. So another problem in the post-ERCP bleeding is the antiplatelet and anticoagulant therapy. So it's well studied for warfarin, it's less studied for the clopidogrel group medication, and there are few studies for the DOACs. So 2 things: when to stop and when to restart after the procedure. There are very good guidelines presented in GUT in 2016, and we have to know ERCP with sphincterotomy or ampulectomy or dilation is a high risk procedure for bleeding. So in the group of clopidogrel in low risk condition, we just stop clopidogrel 5 days before the procedure. Low risk for coagulation, for thrombosis. We stop clopidogrel 5 days before and we continue with aspirin. In high risk condition, that's mostly recently placed at cardiac stents, we have to contact our cardiologist and look for solution if it's possible to make a delay for the ERCP, because this is a dangerous situation. We always can continue aspirin, but we have to ask it to the cardiologist. When we look to warfarin in low thrombosis condition, we just stop warfarin 5 days before the endoscopy. We do a control of the INR, and if it's less than 1.5, we can do the procedure, and on the same day we can restart warfarin without bridging of low molecular weight heparins. When it's a high risk condition of thrombosis, we have to stop warfarin, do a bridging with low molecular weight heparins. That will be stopped 24 hours before our procedure, and then afterwards we have to restart with warfarin and again with low molecular weight heparins. The DOACs, we have to stop them 48 hours before, especially it's important to stop it long enough for dabigatran in patients with renal insufficiency. We have to wait even longer to start the procedure. And then there's some debate on how fast you can restart it. Most studies say that you can restart after 2 days.
In the next 15 minutes, I will talk to you about ERCP-related perforations, probably the most feared complication of ERCP. These are my disclosures. Perforations related to ERCP luckily are not very frequent. We see them in about 0.5% of the ERCP cases, but unfortunately many of these cases are only found after the procedure. When should it be suspected? Well, if the patient presents with abdominal pain, fever, leukocytosis. And I hear you saying this can also be due to pancreatitis. This is completely true. But I think one sensitive sign is that the patient immediately after the procedure has this abdominal pain. This can be related to perforation or a severe pancreatitis. What makes it even more difficult is the fact that 43% of the patients with a perforation also have a post-ERCP pancreatitis. So I think the threshold for a CT should be very low, and CT should be performed in case of suspicion. We still use the Stapfer classification to classify ERCP-related perforations. Type 1 are large perforations caused by the duodenoscope. Type 2 perforations are mostly related to the sphincterotomy, so are near to the ampulla. Type 3 perforations are perforations of the bile duct itself, and type 4 are not real perforations, but this is just retroperitoneal air detected on a CT scan. For all ERCP-related perforations, first thing you should do, if you are still using air, turn the air off and switch to carbon dioxide insufflation. If it is needed to decompress a tensioned pneumoperitoneum, we use an 18 or 20 gauge needle near the umbilicus with the patient in the supine position. And most of the time you can aspirate the air that is inside the peritoneum. All the patients should stop eating, so nil by mouth, intravenous administration of PPIs and intravenous administration of broad-spectrum antibiotics. We recommend nasogastric or nasoduodenal aspiration. And when can you restart oral feeding? Well, this is mostly after 3 to 4 days if the patient is doing well and if there is no further leakage on imaging. What to do if you have a type 1 duodenal wall perforation? This is caused by the endoscope, tends to be large. So early recognition and early closure are really crucial in this regard. Because there are, of course, a lot of intestinal content that will leak into the peritoneum. Endoscopic management can be performed. So if it is detected immediately during the procedure, which is often the case for this type 1 perforation, and if it is less than 12 hours after the procedure, it does not make sense to close a hole if it is already there for more than 12 hours. Duodenal perforations less than 10 millimeters can generally be closed with classical clips. But for larger perforations, I would say 10 to 20 millimeter, you will need other devices such as the over-the-scope clips. And of course you have to be careful that it's not near to the ampulla and that you do not clip the bile duct or the pancreatic duct. There is also in the literature a description of larger duodenal perforations that were successfully closed with stitching, endoscopic stitching devices, but these are only cases. So this is, for example, an over-the-scope clip, and you see here that the twin grasper is used. With the twin grasper, you can grasp the healthy mucosa, retract it back into your cap, and then you fire the over-the-scope clip, and you can close easily perforations of 2 centimeters. What about the type 2 and 3, so the periampular or ductal perforations? Well, most of the cases can be managed endoscopically, also if they are recognized early. So the best outcome for the patient is always if the perforation is detected during the procedure and if the endoscopist can act immediately. The standard treatment for this is a fully covered self-expandable metal stent. This is standard treatment, I think, for the type 2 perforations. And this is to drain the bile ducts and also occlude the leak sites for these type 2 perforations. For type 3 perforations, you can also use a plastic stent to bridge the leak together with the sphincterotomy. Clipping can be applied for type 2 perforations, but you have to be careful to not clip the ampullar orifice because, of course, you will obstruct the bile duct and the pancreatic duct.